All right, so welcome everybody.
Welcome.
Today is like the next day, I guess. This is your last day of training. So
Already?
I know, like time flies, and it's just such an amazing journey, I have no doubt. So this is workshop 5. This is really where we want to talk about trauma-informed approach and how you teach that to in addressing human trafficking.
So, we have in your digital workbook, per usual, some questions to have you think about while we're going through this video. So how have you taught trauma-informed care to your learners? So we really are excited to know about that. How does language influence our perception? Really great question. And then what is one thing you learned in this video?
Yeah, that's all. I mean, that's great. So really, what we want to do for this workshop is really highlight how to teach on trauma-informed care and how to work with interpreters. I really love this quote. Maya Angelou, she said that there's no greater agony than bearing an untold story inside of you. And really, for a lot of our victims of human trafficking, the world has proven to be an untrustworthy place, and people have proven to be untrustworthy. So there's many stories that they have really buried within them. And it's really only through the lens of trauma-informed care that you can really open the door that Hani was talking about in the previous workshops, so that you can build that trust and help them begin the path of healing. I don't think really there's any other way outside the lens of trauma-informed care that you can do that.
I think that's so important. And just speaking personally as an emergency medicine physician, when I hear the word trauma, my initial thoughts are, is it a gunshot wound or is it a car accident? So just realize that with your health professional learners, this may or may not be a familiar topic to expand how they think about trauma.
Yeah.
And just to realize that trauma is any experience that overwhelms one's ability to cope. So the same event can cause trauma in one person and not trauma in another. And there are many different kinds of trauma, including historical trauma and racial trauma.
And that's really important. And I think another thing that's really important for healthcare professionals, others to really understand is really, how does trauma affect the brain? What does,
I'm really curious how Anne Catherine would teach on how trauma affects the brain.
Yeah, I'm really curious to how they would really approach this topic and how they would teach it. In my mind, the way I think about it is, I just kind of want to lay like this broad stroke understanding of how the brain functions when it comes to trauma and stress. And, so kind of thinking in broad strokes, the reality is that we have built-in alarm systems that are designed to detect potential threat and know how to respond and know how to survive. So when you think about that, your brain is kind of divided into these 3 main parts, kind of going a little like we talk about the neocortex, right? We kind of think of that as our thinking brain. So that's really the part of our brain that reasons, plans, problem solves. And when we're faced with danger, that's really the part of our brain that assesses whether there's true danger or not. And then you have what's called the limbic system. And we tend to refer to that as like the emotional brain. So that's really the part of our brain that kind of experiences feelings and fear. It's the one that really sets an alarm when it recognizes like a sense of danger and begins to communicate it to the rest of our body. And then you have what we call the brainstem, right? So that's really what we think about as the physiological functions of our brain. So that's really the part of our brain that takes these messages and then has our body respond to them, whether it's by increasing our heart rate or blood pressure. That's really the physiological response. So then, like in that backdrop, so what really happens when something traumatic happens? So imagine that you're walking in a forest and you suddenly see a bear. So, essentially, this fight, flight, freeze, survival mode suddenly, takes on. And so what happens is the limbic system takes over and it alerts like smoke alarms to the rest of your body that there's danger. And so then what happens is like the neocortex looks at it and determines that there's danger. So when that suddenly you see a bear, what happens is, imagine there's a loud noise, right? Like, so what happens is you kind of jump first, right? You kind of react before you actually
You're not
can
really thinking,
ascertain,
you're just like reacting.
right, like you can, before you really ascertain that there's danger. And that's really what happens with trauma. So once you've reacted and you look around and you confirm that there's a bear, then what happens is the thinking brain kind of shuts off, and your body starts releasing these hormones, these adrenaline, you know, your heart rate starts going up, you know, you're hypervigilant and there's heightened sense so that you can try to survive. So whether it's you flight or you freeze, if there's no opportunity for you to escape, or you fight, you kind of enter into that stress mode. But now imagine if this response, and imagine if this bear came with you when you went home, or imagine if that bear, walked with you into the doctor's office. And so then you're continually like experiencing this stress response. And that's really what happens in trauma. You know, what seemingly seems to be this obvious non-threatening thing like shutting of a door or the way that a name is called may actually trigger these stress responses similar to that bear that's kind of like walking into the room with you. And so, you know, you have to have a trauma lens to understand that.
That makes sense. So is the stress response a problem, or does it help people survive? Like,
I think that's a really great question. And I think that's where understanding trauma-informed care comes into play, because, you know, the fight, flight, or freeze response, they're really activated when there's danger, right, for us to survive. But, you know, when those behaviors occur in situations that seem to be non-threatening, like the shutting of the door, then it can be labeled as a problem, you know. So, you know, for example, if you think of a patient that's like non-compliant and combative, you know, maybe they're actually in the fight state of a stress response, you know. Or if you think of a patient that may be labeled as like treatment resistant or, you know, uncooperative, they may actually be in the flight state of response. Or someone that you may think, oh, like, you know, they're just kind of passive, they may actually be in the freeze state of response. So, you know, a trauma-informed lens really understands and takes into account these elements when they're interacting with a patient. So they're always asking, you know, what are the triggers behind, you know, how they're responding or behaving in this time.
Got it. Well, you know, I like your slide, but I like my slide better.
Love it.
One way of teaching, hopefully, is to incorporate things that are personal and put your own personal touch on them. And I use this slide to train health professionals to think about their patients that they, like you said, might have labeled as agitated or aggressive and just stopped there. And to really help those health professionals to kind of look beneath the surface and be curious, like what's underlying that. And it's because of the remodeling of the brain, which is a survival mechanism, that they might be like that cat in the bottom right, or they might be in the freeze mode, like the cat in the top.
Right, exactly. And, you know, I think that's a really great point. I just really wonder how Vita would tie then this stress response to like trauma reminders
like
and
how
trauma
would
triggers.
Teach that?
Yeah, how would she teach that and tie that together?
Me too. I'm really curious, but I know you didn't ask me, but I'm just willing to share my own.
Oh, okay. Well, sorry, Vita. I wish you were here.
I know. I wish you were here too. So the way that I teach on trauma reminders is actually to share a patient story that really brought this crystal clear to me. So it was like 2 a.m. chaotic emergency department. I had ordered a pelvic ultrasound on a patient who had an infection in her pelvis and didn't think anything really of it. I had ordered the medically appropriate test, and all of a sudden this radiology technologist rushes over to me and he's like, this patient just got off the gurney and she's shouting at me, and why is she being so mean to me? And I paused and I put it like, I had this crystal clear knowledge of exactly what had happened based on a trauma-informed lens, and this being a trauma trigger for her. So for those not familiar, a pelvic ultrasound often does involve a vaginal probe going in the vagina, And the moment that the ultrasound tech, who did have a chaperone, had inserted that, it probably was a trauma reminder for her. And he had mislabeled her behavior as, you know, aggressive to him, when in fact it was, you know, a very natural response, and a trauma reminder.
Yeah, I think that's a really excellent and great example.
So, you know, I love this slide because I really do think as clinicians that there are two options with every interaction with patients. It's binary. Either we're contributing to their sense of safety and healing and trust, or we're detracting from that. And I think that's a call to action for every clinician that you're training on trafficking.
Yeah, and that they should, you know, always have a trauma-informed approach to anybody that they meet. I think that's what I love that. You know, I love this picture, and I want you to kind of explain. Can you just explain this picture?
This is another one of my teaching slides, and I actually forget like every time who this person is because anyway, I love. But every clinician has a sense in their mind of like who a perfect victim is, somebody who like warms their heart and melts their heart and they want to spend time with it. And a lot of times, as we've talked about, because of how trauma remodels the brain, that does not match up with what a potentially trafficked person may look like or behave like in the emergency department. And so I actually have them do like this reflective exercise, and I share, you know, my perfect victim patient is like, or really like my perfect patient is a little old lady in a pink nightgown who comes in the middle of the night. I want to like take care of her. I want to spend all my time in the room. And by having them identify that spectrum and showing them that they're human, it helps them to bring more of their intentionality and curiosity whenever folks are on the other end of that spectrum away from their perfect victim.
I think that's a really great point. I think also that also ties in how we document. You know, sometimes, you know, the way that you document actually paints a picture. You know, it's kind of like, oh, you know, if you pass off, oh, that really cute old lady, she's like 80 years old who came in with a hip fracture versus, you know, like the 32-year-old aggressive combative male that came in drunk, you know. So, you know, how you document actually makes a big difference in how people perceive that, and it influences how they react to them. So it's really important to hone that in to your health professionals. And the reality is that language is not innocent, and it can actually lead to re-traumatization of patients. And there's actually a study that was done that showed that patients with PTSD who where providers used trauma triggering words had a slower rate of responding to what was being said, because it was really emotionally charged. So it's really important to be aware that your language is also part of trauma-informed care. What you say and what you write.
And along those lines, a really interesting study was done where they did presented these hypothetical scenarios that were exactly the same, except that they referred to the patients as either a substance abuser or having a substance use disorder. So like, you know, the person said a language or not. And when the clinicians were reading these scenarios, if the patient was labeled as a substance abuser, and again, nothing else was changed except for the label, they were more likely to be blamed for their substance-related difficulties. They were felt they were more able to control their substance use without any help. They're more likely to be socially threatening. It's just, words are powerful, right?
That's right, they are.
And so the other thing that we wanted to talk about in this presentation, we're going to talk about interpreters in just a second, but you know, recognizing that those that are trafficked have such a diversity of experiences. They're coming from a variety of backgrounds, speak different languages, belong to different cultures. We would be remiss not to talk about how important it is to have a culturally and linguistically appropriate response.
That's right. And I think, you know, just to kind of hone that statement in really, so it's just not training health professionals to have a trauma-informed care, but it's really training them to have a culturally tailored trauma-informed care, because culture influences how we describe trauma, how we experience trauma, how we understand trauma. So for example, you know, when you think about Ethiopian patients, you know, domestic violence has really become part of the Ethiopian culture and patriarchy. So oftentimes, you know, women that are in domestic violent situations will not think of that as trauma. So if you don't understand that lens, then you can miss potentially many domestic violence cases. So you have to have that cultural information about how you address trauma. But the other, I remember I had a Syrian patient, and when you would interview him and talk to him, like, you would never imagine that there was any kind of trauma that has ever occurred in their life. But as we started to share, he pretty much lost everything before he came, including his wife, children, family. And I was completely astounded at the level of trauma that he bears within him. But you never see that in their face, So sometimes, there are cultures that don't show or express emotion or feeling and are very stoic and react differently. And you have to have that cultural lens to be able to really understand and be truly trauma informed.
It's so important.
So I guess I'm really curious, like, what is the big deal about interpreters? Plenty of my patients want to have their family members interpret for them. They actually even prefer that. So what's up with that?
Ooh,
what's up with that?
What's up with that?
What's up with that line?
I know. What is up with that line? I made the animation. I'll blame it on me. So this is a big deal. This is what's up with that. So this is the actual medical record of Juan Carlos, who we've spoken about throughout this training, who was trafficked from Mexico, and actually went to an emergency department in Mississippi. He had been working in the cornfields, and he had heat stroke and was exposed to pesticides. And this is what they wrote in the medical record. Poor historian due to language barrier, very little English, migrant worker with communication barrier due to language. They did not use an interpreter. This is just ridiculous. And therefore, his exploitation was not identified.
Yeah, I think that really leads me to some really important points. And that is that it's never okay not to use an interpreter for patients with limited English proficiency. That is the standard of care, and it should always happen. In fact, there's a lot of research that shows that patients with limited English proficiency have worse health outcomes, worse hospitalization, and procedure outcomes compared to those that speak English fluently. And I think that there was one literature that said that about 43% of emergency departments don't use an interpreter for patients with English limited proficiency. And only 23% of teaching hospitals actually teach their physicians how to work with an interpreter. So this is really an important thing, that as we train on human trafficking, that we train health professionals how to work with interpreters. The other thing is, it's really important to have a trained and qualified interpreter. So in my book, it's really never okay to use family members, and especially when you're thinking about potential traffickers, identifying themselves as mothers or fathers and aunties, so it's never okay to use family members as interpreters. And the other things just to want to highlight is that sometimes, I think that it's always better to use in-person versus phone, but there are circumstances when phone interpretation is better. And that could be cases where I had a Somali patient who, the community was very, very small where they were living, and they were fearful that one of the interpreters could be a part of their community. So to have that added privacy, they prefer to engage with a phone interpreter. So it's important to recognize those kinds of nuances. And the other important thing is, it's always, patients have a right to refuse an interpreter for whatever reason, right? Like, I had a patient that was Arabic speaking, and we had a male interpreter come, and she was not comfortable. And so it's important to even ask beforehand, are you comfortable with male or not? And to recognize that patients have a right to refuse if they're not comfortable with interpreters. And I think, along that line, I think another thing that's really important that I would highlight with health professionals particularly is not only to discuss confidentiality, but you really want to prepare the interpreter for what is going to happen in the room.
Why is that?
Because, I think, so if you're dealing with traumatic stories or cases, those stories can actually be triggering for the interpreter themselves. So I had a case where I had a Rwandan refugee, and so I had another Rwandan interpreter come to interpret. But as she started telling her story of the genocide, he was so affected, and it became like a re-traumatization for them. And so it's really important to prepare them beforehand of what to expect, and it's also important to debrief afterwards.
Can I share a story too?
Yeah, please do.
Yeah, so I had a Spanish interpreter the other day who interpreted for me that I didn't debrief beforehand or after, well, I did afterwards. We walked out of the room and she said, why are you, you got to watch out for people from those countries. They're just going to manipulate our system and try to game our system. And what I was doing was like, I was screening for labor trafficking or assessing for labor trafficking, and was trying to get a sense of like whether his employer was abusing him. And that was her response. So then I went, like, I questioned everything she had translated after that. So it's like really important to talk to them ahead of time and kind of get a sense of their biases too.
Yeah, I mean, that's very true. Because if you have like even a Hutu interpreting for a Tutsi, sometimes there are issues where people don't feel safe to disclose.
Those are like Rwandan.
Yeah, Rwandan tribes, exactly.
Yeah.
And those nuances continue on when they come here. So it's really important to be aware of those things and to train health professionals to be aware of those. So just to kind of highlight, these are just some important points that I think as you train health professionals to highlight that, you want to speak in short sentences. It is going to take time. You can't be done in the same quick minutes that you would with someone that speaks English, and you have to come into it being aware of that. And you don't want to use medical jargon. And I think another thing that's really important is that you want them to repeat back what they understood so that you clearly know that your message has been relayed.
Great points.
So, with that, we finish our 5th workshop. This is actually our second to last. So, oh my word, we're gonna miss you. So as we kind of close this video component of it, we want you to kind of think about what you found interesting or what surprised you from this video.
I wonder what Alicia's
surprises. Yeah, I know. I don't know how Victoria was surprised or not. We'll see. All right. Thank you.